Have you ever wondered how mental health professionals navigate the incredibly complex world of human behavior and distress?
It's quite a task.
Yeah, it's almost like they're detectives, you know? But instead of solving crimes, they're piecing together these really intricate puzzles of our minds.
That's a good way to put it.
Today, we're taking a deep dive into the fascinating and sometimes well-debated world of classifying and assessing abnormal behavior. This deep dive is really for you, whether you're just curious about how psychological conditions get diagnosed, or maybe you want to understand the tools your own therapist might be using, kind of behind the scenes.
And we've pulled together some really compelling material for this. We'll look at the history, how we even started categorizing mental health stuff. We'll also touch on cutting edge things like brain imaging and even explore real world experiences. Like, what's it actually feel like to have a panic attack, and how does a clinician go about assessing that? Our mission really is to sort of demystify how psychological well-being is evaluated, the frameworks they use, and importantly, the lively debates that are always shaping the field.
Okay. All right. Let's peel back the layers then. Let's see what makes this whole system tick. So to kick things off, maybe the fundamental question, why do we even try to classify human behavior, especially when it, veers into what we call abnormal?
Well, historically, people have always tried. Think way back to Hippocrates, or later figures like Emil Kraepelin in the 19th century. Their theories might seem flawed now, but they were trying to make sense of it.
Right, trying to put labels on things.
Exactly. And at its core, classification is foundational to science, isn't it?
Yeah, I suppose it is. How so in this context?
Well, think of it like needing a common language.
Yeah.
In mental health, classification lets researchers communicate effectively, share insights, build on each other's work. Without it, it'd be chaotic.
Okay.
And crucially, it also guides treatment decisions, helps predict maybe future behavior patterns, and lets us identify specific groups for study.
A common language. And when we talk about that common system, the big one, especially here in the U.S., that's the Diagnostic and Statistical Manual of Mental Disorders, right? The DSM.
That's the one, published by the American Psychiatric Association.
Okay.
It's the most widely used diagnostic tool here. The latest version, DSM-5, which came out in 2013, it classifies these patterns of abnormal behavior as mental disorders.
And how does it define a mental disorder? Is it just any unusual behavior?
Not exactly. It's defined by things like significant emotional distress or impaired functioning in daily life, or maybe behavior that puts people at risk. And what's really important to understand is that an expected response, a temporary thing like deep sadness after a loss, that's not seen as a disorder unless, the impairment just goes on and on, way beyond what's typical.
Okay, so it's about the impact and the duration, not just the feeling itself. No, what I find really interesting is this idea of it being like a medical model. It treats these behaviors as signs of underlying disorders. But you mentioned it doesn't just assume biological causes, it's more descriptive. Can you unpack that a bit?
Yeah, that's a really vital point. When we say the DSM is descriptive, not explanatory, it means it focuses on what the symptoms look like. So things like persistent sadness, losing interest in things, changes in sleep, appetite, that kind of stuff.
Okay.
But it doesn't try to say why those symptoms are there. It doesn't dictate that someone's depression is because of a chemical imbalance or stress or childhood issues.
I see.
It just gives the criteria for identifying that pattern of symptoms. So clinicians can make a diagnosis based on what they observe, regardless of their theory about the cause.
So it's the what, not the why.
Exactly.
Yeah.
And the DSM-5 organizes these into about 20 broad categories, like anxiety disorders, depressive disorders, and so on, with specific criteria for each.
Got it. And speaking of how we talk about this, there's been a deliberate shift in language, hasn't there, to be more sensitive?
Oh, absolutely. It's a really important ethical point. Clinicians are trained now to use person-first language, meaning we talk about an individual with schizophrenia or a person with major depression. We avoid terms like a schizophrenic or a depressive.
Why is that distinction so important?
Because it emphasizes the person isn't defined by their disorder. It's something they experience. It's not who they fundamentally are. It's a small change, but it really helps combat stigma.
That makes a lot of sense. A crucial distinction. Now, here's something that always kind of blows my mind. This idea that not all these abnormal behaviors are universal, these culture-bound syndromes.
Right. That's a fascinating area.
I mean, can you believe some men in India experience a disorder called Dot syndrome, where they're terrified of losing semen?
It's documented, yes. And it causes real distress.
Or Taijing Tofu show in Japan. fearing you'll embarrass other people, not yourself. That's so different from social anxiety as we typically think of it here.
It is. And you have things like amok in Southeast Asia, these violent dissociative episodes, or Korto syndrome in China, the fear of shrinking genitals.
Wow. And conversely, things really common in the US, like maybe anorexia or dissociative identity disorder, they're basically unheard of in some other cultures, especially less developed ones.
That's largely true, yes. Which brings up a huge and pretty contentious question.
Here it is.
Well, if so much distress is shaped by culture, how universally applicable can a system like the DSM really be?
Good point. Is the DSM-2 American-centric?
That's the criticism. Critics argue its criteria come from a consensus of mostly U.S.-trained professionals. So potentially, it might lack sensitivity to global cultural ethnic differences. Now, later versions, including DSM-5, have definitely tried harder to emphasize cultural factors in assessment, but the basic framework's universality, that's still very much debated.
So, stepping back, what's the core takeaway here about the DSM? It sounds like it has big strengths, that common language, the consistency.
Absolutely. Those are huge strengths.
Right.
Providing specific criteria gives clinicians that common yardstick.
But it's also really controversial. What are the main sticking points?
You nailed it. It's kind of a double-edged sword. The big controversies often revolve around that medical model focus. Does it oversimplify? Does it maybe overlook crucial external factors like social or economic pressures?
Right.
And then there's this concern about something called diagnostic inflation.
Diagnostic inflation. What does that mean? Sounds worrying.
It can be. It's the idea that maybe new disorders are being added, or the definitions of existing ones get broadened, and this potentially medicalizes everyday problems.
Medicalizing normal life.
Kind of. It could lead to more people getting labeled with a mental disorder when maybe they're just facing significant life challenges. Like the example often given is how frequent temper tantrums in kids are now potentially classifiable as disruptive mood dysregulation disorder.
Huh. So it blurs the line between typical struggles and a diagnosis.
Exactly. It raises the question of where we draw that line.
And this ties into another debate too, doesn't it? Categories versus dimensions. Is mental health like, yes, no, you have it or you don't? Or is it more of a spectrum?
That's another key tension. The DSM traditionally relies heavily on a categorical model. It's basically a yes-no judgment for diagnosis.
Right.
But many argue for a dimensional model, viewing problems like anxiety or depression along a continuum, from mild to moderate to severe, not just you have it or you don't.
Why does that matter?
Well, the categorical model can feel a bit arbitrary sometimes. You might hear the joke, it's like a camel being a horse designed by a committee. Because needing, say, exactly 5 symptoms out of 9 can feel random. What if someone has 4 very severe symptoms and is really struggling, but doesn't meet the threshold?
Yeah, that doesn't seem quite right.
To be fair, the DSM-5 did try to move in that direction by adding some dimensional components to rate severity for certain disorders. So there's some evolution there.
Okay. And this push towards dimensions or maybe looking for common threads across different diagnoses that leads to this transdiagnostic model idea.
Precisely. The transdiagnostic approach tries to find common underlying features or processes that cut across different disorders.
Like what?
Like, say, lack of motivation. You see that prominently in depression, but also in schizophrenia. Or maybe difficulties with emotion regulation, which pop up in lots of conditions.
And the hope is?
The hope is that if we can identify these shared core processes, maybe we can develop new treatments that target those processes directly, rather than just treating the symptom cluster of a specific diagnosis. It could be more efficient, more targeted.
Interesting. So despite all the controversies, the debates about categories, culture, inflation, and of course the ongoing concern about stigma and labeling.
Yes. Despite all that, the DSM remains a really critical tool, mainly for communication among professionals. But it's definitely a work in progress, constantly evolving. Now, switching gears a bit. Whatever classification system we use, the methods for assessment are just crucial. If we're evaluating someone, our tools absolutely have to be reliable and valid. Okay, reliability and validity. Let's break those down. Reliability first. What does that mean in this context? Reliability is all about consistency. Does the test or the assessment method give you pretty much the same results if you use it again under similar conditions?
Like a good bathroom scale.
Exactly like a good bathroom scale. We look for a few kinds of reliability. Internal consistency. Do different parts of the same test give consistent results? Retest reliability. If you take the test today and again next week, do you get similar scores?
Okay.
And inter-rater reliability. If two different clinicians use the same assessment tool or observe the same behavior, do they generally agree on the findings?
Got it. Consistency across the board. So what about validity then?
Validity is arguably even more important, it asks. Does the assessment actually measure what it's supposed to measure? Is it accurate?
Right, accuracy.
And there are different types here too. Content validity. Does the test cover all the important aspects of the thing it's measuring? Like, does an anxiety test cover worry, physical symptoms, avoidance, etc.?
Makes sense.
Then criterion validity. Does the test score correlate with some other independent standard or outcome? A key type here is predictive validity. Does the test predict future behavior or performance? For example, does a test for job aptitude actually predict success on the job?
Okay.
And finally, construct validity. This is a bit more theoretical. Does the test score align with the underlying theory or model of the trait being measured? If our theory says anxiety involves certain thought patterns, does our anxiety test actually tap into those patterns?
It sounds like you really need both, reliability and validity.
Yeah, absolutely. You can have one without the other, surprisingly.
How so?
Think about those 19th century phrenologists we mentioned earlier. They could measure the bumps on people's heads very reliably. Two phrenologists would likely get the same measurements.
Okay, consistent.
But were those measurements valid indicators of personality traits or intelligence? Absolutely not. So they had reliability, but zero validity. They were, as you said, bumping in the dark.
Huh. Right. So that answers one of our truth or fiction questions then, the idea that head bumps determine personality. Definitely false.
Definitely false. The key insight is, for any assessment to be useful, whether it's mental health or anything else, you need both consistency and accuracy. Without both, the results are pretty much meaningless. Building on that need for valid assessment, it's crucial to remember we don't currently have, say, a simple blood test or a definitive brain scan that can diagnose complex conditions like major depression or schizophrenia. Not in the way we diagnose diabetes, for instance.
Not yet, anyway.
Not yet. So assessment nearly always starts with the clinical interview. Remember Jerry, the example you mentioned, who had that terrifying panic attack on the highway?
Yeah.
His first visit to a clinic, it would absolutely begin with an in-depth interview. The clinician would need to explore the nature of his panic, when it started, how it's affecting his life.
What kinds of things do these interviews cover typically? Is it just about the main problem?
They cover essential ground, usually. Identifying information, the presenting problem, of course, but also their psychosocial history, relationships, work, stress, and their medical and psychiatric history.
And are all interviews the same? Or do they vary?
They vary in structure. You have unstructured interviews, which are very free-flowing, conversational, letting the client lead more.
Okay.
Then semi-structured ones, where the clinician has a general outline of questions but can be flexible, ask follow-ups, probe deeper.
Right.
And the structured interviews. These use a preset, standardized list of questions asked in a specific order. They offer very high reliability, which makes them great for research. The SCID structured clinical interview for DSM disorders is a common example.
Now, what about computers? I've heard about computerized interviews. It sounds a bit impersonal, maybe.
It can seem that way, but it's fascinating. Some studies suggest people might actually be more willing to share sensitive information with a computer.
Really? Why?
Perhaps feeling less judged, less self-conscious. Plus, they can be very time efficient, potentially less expensive.
But what's the downside?
The huge downside is the lack of human connection. The computer can't pick up on nonverbal cues, body language, tone of voice, hesitation, that subtle stuff a skilled clinician notices.
So the ideal might be a mix.
Often, yes. Combining the efficiency of computerized tools with the nuanced judgment and empathy of a trained human clinician probably gives the best results.
Okay. So beyond the interview, clinicians often use specific tools, right? Psychological tests for things like intelligence or personality.
Exactly. These are more structured methods to evaluate relatively stable traits. Intelligence tests like the Stanford-Binet or the Vessler scales are really important tools.
How do they help in assessment? Are they just about getting an IQ score?
Not just that. They help diagnose intellectual disability, assess cognitive impairment perhaps after an injury, and really importantly, reveal individual strengths and weaknesses. The Vessler scales, for instance, give you scores across different areas: verbal skills, spatial reasoning, working memory, not just one single number. It provides a profile.
A profile. Okay. And what about personality? How do you test for something so complex?
Well, for personality tests, we usually talk about two main types, objective and projective.
Objective tests, like multiple choice.
Sort of. Objective tests like the MMPI-2, the Minnesota Multiphasic Personality Inventory, or the MCMI-3, the Clinical Multi-Axial Inventory. They're usually self-report questionnaires. You answer a whole bunch of statements, often with limited options like true or false.
And that makes them objective.
Yes, because the scoring is standardized, leaving very little room for the examiner's personal interpretation or bias. The MMPI-2, for example, has over 500 true-false questions.
Wow.
And it cleverly includes validity scales. These are designed to detect if someone might be trying to fake good, present themselves in an overly positive light, or fake bad, maybe exaggerating symptoms.
That's clever. Okay, so those are objective tests. What about the other kind? Projective. They sound more mysterious.
They are a bit different, yeah. Projective tests don't give you clear options. Instead, you're presented with ambiguous stimuli like, well, ink blots.
Ah, the Rorschach. So is this true then? One of the most widely used personality tests actually asks people to interpret what they see in ink blots.
That's absolutely true. The Rorschach ink blot test is probably the most famous example. Its creator, Hermann Rorschach, was apparently obsessed with ink blots as a kid. His nickname was even Klecks, German for ink blot. Sadly, he died very young, just months after his test came out.
Wow. So what's the theory behind showing people ink blots, or like the TAT, the thematic apperception test, with those ambiguous pictures?
The core idea is projection. Because the stimulus is vague, the theory goes, you'll unconsciously project your own thoughts, feelings, needs, and conflicts onto it when you describe what you see.
So it's like a window into the unconscious.
That's the traditional psychoanalytic view, yes. However, it's really important to mention that the reliability and especially the validity of many projective tests are still heavily debated in the field. Scoring often relies a lot on the clinician's subjective interpretation, which can be problematic.
Okay, so more controversial than the objective tests.
Generally speaking, yes.
Let's shift gears again. Neuropsychological assessment. What's that about? Brain damage.
Essentially, yes. These tests are designed specifically to figure out if psychological problems, memory issues, concentration difficulties, personality changes might be linked to underlying brain damage or dysfunction, maybe from an injury, stroke, or illness.
And how do they test for that?
There are various tests. Some are relatively simple, like the Bender Visual Motor Gestalt test, where you just copy geometric figures. Difficulties there can suggest problems with visual motor coordination, sometimes linked to brain damage.
Okay.
Others are much more comprehensive, like the Halstead-Reiten Neuropsychological Battery. It's a whole suite of tests looking at memory, attention, language, motor skills. It can not only suggest if brain damage is present, but sometimes even help figure out where in the brain the problem might be located.
That sounds incredibly useful. Which brings us back to brain scans. We talked about how they can't diagnose things like schizophrenia yet, but they must be useful in assessment somehow, beyond just the neuropsych tests.
Oh, absolutely. Well, they don't give us a diagnosis for most mental disorders. Physiological measurements, including brain imaging, add valuable pieces to the puzzle.
We sometimes hear about things like measuring sweat with GSR or muscle tension with EMG.
Right. Those measure peripheral physiological responses, often related to anxiety or stress. But the brain imaging techniques give us a direct window into the brain itself.
So remind us what those are again.
Sure. You have the EEG electroencephalogram, which records the brain's electrical activity, those brain waves, very useful for things like epilepsy.
Okay.
Then structural scans. CT scans use X-rays for 3D images of brain structures. MRI magnetic resonance imaging uses magnetic fields and radio waves for even more detailed pictures of brain structure without X-rays.
And the ones that show activity.
Right, functional scans.
Right.
PET scans, positron emission tomography, track glucose metabolism to show which brain areas are most active. And fMRI, functional MRI, tracks oxygen levels in the blood to map brain activity during specific tasks, like thinking or feeling emotions.
Okay, so with all this tech, does it mean physicians still need surgery to study the brain? I'm thinking that's false now.
That's definitely false for most research and diagnostic purposes, yes. These non-invasive techniques are revolutionary.
And is undergoing an MRI really like being stuffed into a giant magnet?
Well, essentially, yes, that's true. It's a very powerful magnet.
Okay, but the big question remains. Even with fMRI showing activity, can these scans diagnose something like schizophrenia today?
And the answer there is still false. Researchers are using these tools intensely, looking for subtle patterns, differences in structure or activity associated with disorders like schizophrenia. They provide incredible insights for research.
Yeah.
But we're not yet at the point where a scan alone can provide a clinical diagnosis for these complex conditions.
Not yet. Okay, let's move to a completely different approach. Behavioral assessment. What's the focus here?
Behavioral assessment shifts the focus away from internal traits or brain structures and looks directly at observable behavior in specific situations. Very practical.
How does that work?
Often, it involves something called a functional analysis. The goal is to identify the ABCs, the antecedents, what triggers the behavior itself, and the consequences, what happens afterwards that might be reinforcing or maintaining the behavior.
ABCs. Okay, can you give an example?
Sure. Think about Carrie, the example of the 7-year-old, the royal terror, having severe temper tantrums.
Right.
A behavioral psychologist might do direct observation, maybe in the home or through a one-way mirror in a clinic playroom. They'd watch closely. What happens right before the tantrum starts? Antecedent, maybe being asked to do something. What does the tantrum look like? Behavior. And how do the parents react? Consequence, do they give in? Do they get upset?
Yeah.
They look for patterns that might be unintentionally reinforcing the tantrums.
So understanding the whole cycle in context, that makes sense. What about tracking your own behavior?
That's called self-monitoring, and it's a really common and powerful technique. The individual tracks their own behavior, thoughts, or feelings in their daily life.
Like keeping a diary.
And exactly, like recording everything you eat if you're trying to change dietary habits,
Yeah.
or logging how much time you spend studying, or noting down when and where anxious thoughts occur. It increases awareness and provides valuable data.
And technology must be playing a role here too. I saw something about an app to test infants for autistic behaviors. Is that true?
That is true. There are apps being developed for early screening, not diagnosis, that's crucial, but screening for potential signs of autism spectrum disorder in infants by analyzing things like eye contact or responses to stimuli.
Wow.
And we see it everywhere now, right? Apps like iMood Journal for tracking mood, the government's PTSD Coach app for managing symptoms. Even I read about a client with hoarding issues sending her therapist digital photos of her home to monitor progress. It gives a real-time window into daily life.
That's amazing. Okay, so that's behavior. What about thoughts? How do clinicians assess those internal states? That seems trickier.
That's where cognitive assessment comes in. It focuses specifically on measuring thoughts, beliefs, and attitudes. Cognitive therapists work from the premise that dysfunctional or negative thought patterns often contribute significantly to emotional problems like depression or anxiety.
So how do you measure a thought?
Well, you can't directly, but you can use tools to help people identify and report them. Aaron Beck developed tools like the thought record or thought diaries, where clients learn to catch those negative automatic thoughts that pop into their head, write them down, and examine them.
Like challenging your own thoughts.
Exactly. And there are also more standardized questionnaires like the Automatic Thoughts Questionnaire, ATQ, which asks how often you have certain types of negative thoughts, or the Dysfunctional Attitude Scale, DAS, which measures underlying rigid beliefs or assumptions that might make someone vulnerable to depression. It's all about trying to get inside that black box, as they say, of internal cognitive states.
Okay. Now, finally, let's bring it back to something we touched on earlier, sociocultural factors. How does culture impact the assessment process itself? It seems critical.
It is absolutely critical. If we're connecting this all back to the bigger picture, we have to recognize that assessment techniques, even ones that are reliable and valid in one culture, might not be in another, even with careful translation. Well, think about language nuances. Someone mentioned earlier, a study found Spanish speakers might be judged as more psychologically disturbed when interviewed in English compared to Spanish, just because of how things are expressed. Or maybe testing anxiety in a second language.
Right.
Or the example you gave, a clinician realizing a patient saying, "I feel like I'm jumping out of my skin," wasn't expressing a bizarre delusion, but using a common cultural idiom for intense anxiety.
So the clinician needs to be really culturally aware.
Acutely aware. They need to be mindful of potential cultural biases in the tests themselves and in their own interpretations to avoid mislabeling normal cultural differences or expressions of distress as being pathological or abnormal. Understanding the individual means understanding their cultural context. It's inseparable.
Wow. So we've really covered a lot of ground today. We went from the big picture, classifying behavior with the DSM all the way down to the specific tools, interviews, tests, even brain scans.
Quite a journey.
Yeah, and we saw how vital both reliability, consistency, and validity accuracy are for any of these tools. And overlaying all of it, this crucial role of culture in understanding and assessing well-being.
Absolutely. And it's clear the whole field of classification and assessment is incredibly dynamic. It's always changing, evolving with new research, new technologies, new ethical considerations. We've touched on the strengths, having that common language is invaluable, but also the weaknesses, the controversies, the debates. Those are what keep pushing the field forward, hopefully towards greater precision and cultural sensitivity.
Definitely. So as you, our listener, reflect on this deep dive, here's maybe a provocative thought to leave you with. In our world today, which is just increasingly saturated with digital data, self-help apps, endless online information, even maybe those self-diagnosis quizzes, how might our understanding and maybe even our actual experience of what we call abnormal behavior continue to shift in the years ahead?
It's a great question.
Yeah, what completely new insights might future technologies, things we haven't even imagined yet, reveal about the human mind? And how could that fundamentally change how we approach mental health altogether?
Lots to think about. We really hope this deep dive has given you a valuable shortcut to feeling more informed about this complex area and maybe spark some new questions and curiosities for you to explore further.